my task today, I'm going to be talking about the issues of adolescence, which is my favorite topic. I used to be a pediatrician who take care of very small babies, but now I grow up with them. They grown. So I'm growing with them, just like perinatal HIV. Before we get to know each other for too good, then they already, boom, go up to be adults. And now we have another group of adolescents who are sexually acquired HIV. So the topic I'm covering today is about the epidemiology, ART, for the newly infected cases, the experienced cases, and the challenges and complications, and finally with the transition to adult care. And we have two distinctive adolescents with HIV, the ones that grown up who know HIV very well, but they have a lot of adolescent issues, similarly to the behaviorally acquired HIV who may not accept the treatment. They all have the same problem. Around the world, there are about 1.5 million of adolescents living with HIV, and about 150,000 new cases come in globally, identified each year. And this is interesting that girls are predominant than boys, for the newly infected cases. And globally, around 4,000 new cases per day globally. 40% of them are the people who are younger than 25. And again, when you said younger than 25 is youth. And when you said younger than 20 is adolescent. So I'm going to be mixing about youth and adolescent, okay? For Thailand, about half of newly infected cases are younger than 25. One thing we need to bear in mind about the development of adolescence. That is the rule globally, regardless of ethnicity. The puberty hits the girl earlier at about 10 years of age, while the boys seems to be later in maturity for puberty. Their cognitive maturation occur around 12. So every one of us who have adolescents at home, you can realize that before 12, they are just like boys and girls. But after 12, they are a little bit different and become more and more mature. And particularly on the psychosocial maturation, it's also start at 12. And takes a long time to get into mature adults. And some people say that even in the 30-year-old, they continue to be maturing in the development. So at the age of early adolescence, they stick to peers, same-sex peers with parents. They are quite ambitious. They have a lot of peer pressure. They are impatient. But during the mid-adolescence, this is the very dangerous age range where they have a lot of disagreement and they're very confident, no fear, ready to take risks, and starting to have sexual orientation. And this is the age where we pediatricians see HIV new cases, infected cases, as well as in the later stage at 17 to 21, where they accepted more, they're starting to have stable partners, become with moral and wiser, and set goal, still have rigid concepts. So it takes another few years beyond 25 before they can be accepting and become full adult. So let me start with one of my patients, a 16-year-old boy, MSM, referred from Standby U for the positive HIV self-test. He is a very busy boy, has a lot of activities and hobbies. So what would be the good option for this naive adolescent? Before I move on to the choice of the antiretroviral regimen, I'd like to emphasize a bit about that. The key population, only half of them get to test. And this is for MSM, and this is for Thailand. And among male sex workers, this proportion is a bit higher than other groups. Globally, only about 85% was achieved for the first 95 target that we set up. So we need to do better in terms of getting them to test. And we launched a program called Stand By You by a lot of social network, particularly Line. And this is a very simple application that the young people can request online counseling and deliver free self-tests to their home. And back to the, this case, what is the principle of ART initiation in the new case of HIV in adolescents? We need to make it simple, preferably FDC, mindful about the pill size, and we need a lot of support, need to talk to them, and keep confidential. And if possible, we try to initiate the ART as early as possible. Within 7 days, it's possible, or even in the same day. However, it's not always be easy to make it in the same day. But we'll do everything trying to knock down all the barriers that would delay the treatment. And we have two guidelines, well-known guidelines for ART initiation regimen. And of course, the WHO has issued this guideline that dolutegravir is the preferred regimen, and alternative is efavirenz-based regimen. For the IAS, the adolescents and adults have the very similar recommendation preference regimen, not just dolutegravir based, but also bictegravir, Bictav. These two are the preferred recommended regimen right now, and dual regimen like DTG and 3TC for those who are less than 500,000 copies without hepatitis B co-infection can start with dual drugs. And for those who had breakthrough infection following PrEP, they should have genotype before initiating the treatment. And of course, everybody is talking about DTG. The first day we have the session on pediatric DTG. And I think DTG has been implemented worldwide now and starting to be available, become more and more available very soon. Of course, because they are, the drug is more effective, particularly had good viral suppression faster with better CD4 recovery, effective against HIV-2, lower adverse events, have effectiveness against the resistant strain, have higher genetic barrier, more forgiving, and particularly more forgiving. This is very important for adolescents, and lower drug interaction once daily and can be STR and cheaper. And for this boy, young boy, we have choices TLD and TLE, where TLD is not available, or dual or Biktarvy. And let's see the size of the pills. And these are the STR that are available for adolescents. And you can appreciate the yellow ones are the ones in the guidelines, but the one with the stars are only available by our universal coverage in Thailand. For dolutegravir in children and adolescents has the very good study, Odyssey, where many of the children and adolescents in this study are from Thailand. And when we look at the 700 children, those who received the first line in Odyssey A, Arm A, at 96 weeks, it was found that the failure rate was much lower than the standard of care regimen. What about the dual regimen DTG 3TC? And this is the DANCE study presented actually by Dr. Tanjui is the first name here, presented in the international workshop last year. And it was found that the viral load suppression, the virologic efficacy is very good, very similar to the Gemini study in adults. So we can use that, but bear in mind that it has to be lower viral load, lower than 500,000 copies. People worry about the DTG for women with childbearing age. despite the risk of neurotube defect of DTG for women during conception, for fetus during conception, after modeling the cost effectiveness, we found that for every single case of the neurotube defect or the infant's adverse outcome, what we gain by using DTG-based regimen is that we can prevent 21 deaths among women, prevent 26 sexual transmission, and prevent 14 mother-to-child transmission with additional 125 deaths. So no wonder why all the regimens, all the recommendations suggest DTG despite even in the population with childbearing age and of course in adolescents. What about BIC? This is one of the preferred regimen because it has a very high potency and it has very similar viral efficacy. Adult formulation of BIC-TAF is approved in adolescent 25 kilos or up. There's a pediatric formulation, FTC, that has been approved from 2 years of age or older, but we don't have it in here for the pediatric formulation in Thailand. We have there are several data in adults of BIC-TAF, and of course, there's a good data in adolescents as well to support all this approval. Be mindful for the size of the pills. And some adolescents, they prefer smaller size of the pill, although they have to take more numbers. But some adolescents instead, they prefer one single pill, although it's a bigger size. That's why BIC is very attractive because it has a smaller size. So I have the second adolescent who failed protease inhibitor regimen as a second-line regimen and unable to control the virus. And you can see the genotypic resistance here that, all green for protease inhibitors, which is the regimen she's been receiving. This is so clear that she doesn't take it. And adolescent has poorer in the HIV care continuum, has poorer viral suppression. And this is in the US, this is in Thailand. In adults, you can have more than 96% of adults with viral suppression, but for adolescents, you have it less than 90%. And when we look at the treatment failure, this is the rule. It happened about 3% per year, but in adolescents, particularly the older ones, they have like almost 2 times that the risk of the virologic failure over the time. So the second-line regimen, what do we do? In WHO recommendation, of course, the recommendation is dolutegravir in those who never received dolutegravir in the first line. However, those who receive the first line dolutegravir, the second line will be protease inhibitors. And the IAS guideline is very much the same thing with additional of bictegravir. And when we look at the Odyssey Arm B, cohort B, we found that at 48 weeks of the treatment, the dolutegravir arm was better than the standard of care. But at week 96 and week 144, the significance has lost. All because of adherence. We need to support adherence. Speaking is so simple, but working on adherence with adolescents is a challenge. The simplify of the regimen, the design of child-friendly reminder system, develop the plan in partnership, arrange the environment, some tools to help, psychological support, and a lot of motivations. But sometimes the environment arrangement is very important, like this adolescent we have. Just before moving to be with her mom, she has like failing. But after moving to be with mommy, then her viral load suppressed, her CD4 recovered. And we need to have reproductive health service together to support them. And this will make them in good retention as well, and of course, free of charge. So I have another girl who never failed with following the lopinavir first-line regimen and then switched to efavirenz-based. And you can see the viral suppression is so good. And now this girl at this time, should we change the regimen, switch to TRD? And of course, WHO recommend that we should switch from TRE to TRD regardless of viral load. There are so many studies and data that have support this. For adolescents, there are fewer data that's available of the switching from TLE to TLD. But I'd like to share with you one of the study that's impressive on the community base in Zimbabwe of 184 adolescent participants. And it was found that 76% before switching were viral suppressed, but after switching, the viral suppression, which was like the viral load of less than 1,000, was found to 95%. You can appreciate that the number of those who never suppressed become suppressed after switching to TRD. And for the settings where TRD is not available, ripivirine is quite good. We did this in multiple centers in Thailand, supported by Amphitrid Asia, and that has supported this study. And we found that the ripivirine in adolescent, for adolescents who never fail, like this girl, is very good, can maintain viral suppression. And one of the good things is that we have accessed the neuropsychiatric tests, several battery of the tests, and we found that executive function improved after switching. So this is one of the good choice. Back to this girl, what we found is that when we review the medical records, we found a few times that she has proteinuria, stress and 1+, and the eGFR starting to drop. So, of course, TLD may not be a good choice. It's a matter of time. Adolescent who has been receiving tenofovir, we need to stop it at one point because of the renal adverse effect. And Juluca could be, dolutegravir could be a good choice. These are the data in adults. Everybody have seen that, and the HHS guideline suggests that it can be switched to Juluca in those who have good viral suppression for more than 6 months and have no failure before or no known mutations with these two drugs. But the data in adolescents lacked. And the other choice is DTG3TC dual suppressive regimen for these adolescents. And there are lots of data in adults that found very high efficacy of maintaining viral suppression. Unfortunately, there is no data in adolescents. And this is the DHS guideline that the panel does not recommending the use of two-drug simplification in adolescents, unfortunately. However, there is another sentence said that the panel usually endorses the use of adult formulation in adolescents, and these products may be appropriate for some certain adolescents. So I always tell my folks that go ahead and use it. This dual regimen, Juluca and Dovato. Okay, for simplification, but make sure that they do not have the drug-resistant virus. And be careful about the weight gain, because dolutegravir in adolescent could increase the weight. The BMI increased from 0.3 per year to 1.2 per year, which is something adolescents don't like. So we need to be careful. Don't forget about making them exercise and be careful about their diet. And now we have long-acting cabotegravir or piperine, which is very excited. In adults, it's approved last year, the year before, and in adolescents, it's approved last year. And this is the data everybody have seen, except for the injection site reaction. Other side effects are well tolerated, are mild and not a lot, and the virologic suppression is quite well. And adolescent has been approved because of this study, of the PK study, that found that the PK of the injectable drugs are comparable to adults, and this is cabotegravir and this is piperine. And I have a few adolescents that joined this study, and they say they love it in the study, and they wish that all other adolescents just like them can receive the injectable drug. So we need to work hard, Janket, to get the injectable drug to Thailand and for our adolescents as well. And just be careful that these injectable drugs has to be used only when these adolescents are stable on ARV with good viral suppression, no history of treatment failure, and no known or suspected resistance to cabotegravir or piperine that are the active drugs. The oral meds lead-in is optional. It doesn't need to, but it is optional for someone who wants to test whether the patient can tolerate the drugs. Now, I have a few more minutes here. I have the adolescent who has been taking the medications for a long time and failed with all the resistance in all three classes. And we found that adolescent who has been receiving the second-line PI regimen, a third of them will fail in the first year. And of course, the third-line regimen will be more challenges, and mostly are darunavir-based regimen, plus minus with dolutegravir. And the WHO and IAS recommendation, they are pretty much the same, that recommending DRV boosted darunavir with dolutegravir. However, dolutegravir with 2 NRTIs can be used keep in mind that there are about 4% chance of failure. And I'd like to mention about lenacapavir a little bit, that it has been approved in adults just recently. And I'm looking forward that it's going to be approved for adolescents very soon, because there are some numbers of participants in adolescent age, older than 12 years of age, participated in this study as well. So we are looking forward to this drug, particularly for someone like this adolescent that I have extensive drug resistance. So many other issues we have to care about for when we treat adolescents, particularly the long-term complications, STI, gender dysphoria, mental difficulties, disclosure problem, and transition to adult care. And particularly the perinatal HIV, they have been long time, treating with very old generation of antiretroviral therapy. So they have a lot of problems, cardiovascular risk with dyslipidemia, insulin resistance, or even diabetes, cardiomyopathy. They have renal insufficiency, neuropsychiatric problem, and fracture risk. So be alert for STI and gender dysphoria. We have syphilis, we have many other STI increased in even non-HIV adolescents. And of course, they are in the same population. So it's not surprised to see higher incidence recently of syphilis in adolescents. And like this boy, she's a beautiful boy, and she's been taking her gender-affirming hormone. And very fortunate, the current antiretroviral therapy that we have been using right now is not we don't have drug interaction with the the gender hormone. And don't forget to give the HPV vaccination to them, because they have a higher risk of HPV infection. We done a very short cross-sectional study in our center, and we found that mental health difficulties, particularly the anxiety and depression, is found in adolescent and young adult in about 20% of them. In the US, perinatal HIV, who have 70% of them meet the criteria of psychiatric disorder. So these are the challenges that we have to deal with. So make sure that we encourage them to exercise every day and vigorous exercise at least 3 days a week. And limited the time on screen. And we need to arrange our service to be adolescent-friendly, provide community-based approach, and provide psychosocial intervention. And this is my very last slide, transferring to adult care. We pediatricians can end the job by transferring to our adult clinic, and we can have it transition very smoothly if we transfer a little later. After 20 years of age, we found that the transition outcome will be much better. And many of us graduate from pediatric clinic and also graduate from college, and now they become adults. And thanks to everybody from the past and all of us in here to make the ART available to them, from development to making it availability so that they become adults, a good part of our society. Thank you for your attention.
Hi, good morning. I'm Dr. Satya from Malaysia. In Malaysia, age of consent is 18 years old. And can I know your experience with consent in adolescent age group and the possible litigations that you face treating 14 years old, 15 years old without the consent from the parents? Thank you very much.
Well, thank you for that question. I skipped those slides. I have too many slides. But the consent here is no age limit. We work a lot on this through the Medical Council and the national law, and consent for testing is no age limit at all. But consent for treatment is another story. You might need consent for, could be just verbal consent, for treatment for those who are already positive. This is just to make sure that they have someone to take good care of them while on treatment. But for consent for testing, you can have like self-test available free of charge, delivering to them to their home, or testing in your clinic without consent. You should work on that.
Is there any more question or comment from the floors? Yeah, I didn't see any. Yeah, so thank you very much, Professor Kulkanya.
Thank you.